Hello everyone, and welcome. This presentation is brought to you by AZCare. Together, we'll explore the world of scientific publications, breaking down complex research into clear and meaningful insights. Ever wondered how doctors predict risks before surgery? We are exploring tools that make surgery safer. I am joined by AZ, our AI agent, to help us understand this topic. Welcome, AZ. What is our topic today?
We are discussing tools that predict potential problems before surgery and which ones work best.
Z, why is preoperative risk assessment so important?
Major non-cardiac surgeries have about a 3% risk of serious heart or brain issues. Assessment helps identify and prevent complications in at-risk patients.
Which main tools are used for this?
The Revised Cardiac Risk Index, or RCRI, and the American College of Surgeons National Surgical Quality Improvement Program, or ACS-NSQIP. Before diving into the paper, let me introduce AZCare. Americans spend nearly 1 billion hours on hold each year. AZCare's HIPAA-compliant AI agent, AZ, saves time by booking appointments, resolving billing issues, and more.
Now let us explore the key features of these risk assessment tools. What risk factors does the RCRI consider?
6 factors: high-risk surgery, ischemic heart disease, heart failure, cerebrovascular disease, insulin-dependent diabetes, and high preoperative creatinine.
And what about the ACS-NQIP?
5 factors: surgery type, patient functional status, abnormal creatinine, age, and American Society of Anesthesiologists, or ASA class.
What was the study's overall goal?
To compare these tools across 16 studies and recommend the best calculator for different surgeries.
Let us examine how the American College of Surgeons National Surgical Quality Improvement Program, or NSQIP, performed across different surgical areas. How effective was the NSQIP for intra-abdominal and vascular surgeries?
It was generally unreliable for predicting outcomes in these surgeries, showing low predictability. For example, for open abdominal aortic aneurysm repair, predictability was 0.51, and for endovascular aneurysm repair, it was 0.02.
What about transplant and neurosurgeries?
For transplants, no correlation was found with adverse events. In neurosurgery, results were mixed, accurate for elective craniotomies and effective for spinal surgery in larger studies, but not predictive for geriatric lumbar surgery. The predictability for spinal surgery showed an area under the curve of 0.669.
Now, we will look at the Revised Cardiac Risk Index, or RCRI's performance in various surgical settings. How did the RCRI perform for intra-abdominal surgeries?
It showed mixed results. It was unreliable for aortic aneurysm repairs, but reliable for major digestive, breast, or vascular surgery in patients over 65 years old.
And for vascular surgery?
It was generally ineffective, showing predictability values of 0.17 and 0.002 for specific procedures. However, some studies using odds ratio, or OR, showed positive associations with OR values of 3.9 and 1.73.
What were the transplant and neurosurgery results?
The RCRI was reliable for liver and kidney transplants, showing an adjusted OR of 4.35 for liver transplants and an area under the curve, or AUC, of 0.77 for kidney transplants. In neurosurgery, it was predictive for elective craniotomies in small studies, but unreliable for spinal fusion in larger studies, with an AUC of 0.54.
Let us explore how doctors can improve these tools using biomarkers. How did combining NSQIP with biomarkers impact predictability?
It significantly improved predictability for non-cardiac surgery, achieving excellent results with an AUC of 0.941 when combined with 3 specific biomarkers.
Did biomarkers also boost RCRI's accuracy?
Yes. Its predictability was greatly enhanced when combined with biomarkers like N-terminal pro-B type natriuretic peptide. For example, with high-sensitivity cardiac troponin T, or HS-CTNT, the AUC was 0.716 compared to 0.59 for RCRI alone.
So integrating biomarkers makes both tools highly effective?
Exactly. Integrating biomarkers significantly boosts their effectiveness, even achieving an AUC of 0.909 in one study for major elective vascular surgery.
Finally, we will summarize key findings and give recommendations for using these calculators. AZ, which calculator was more effective overall?
The RCRI was more consistently effective for intra-abdominal, vascular, and transplant surgeries.
And what about the NSQIP?
It was generally less reliable for most surgeries, with neurosurgical procedures being an exception.
For non-cardiac surgery, how did both perform?
Both showed high effectiveness when supplemented with specific biomarkers.
Based on the table, what are the top recommendations for different surgeries?
The RCRI is recommended for intra-abdominal, vascular, and transplant surgeries. The NSQIP is recommended for neurosurgery.
What if biomarkers are used with non-cardiac surgery?
When biomarkers are added, either the RCRI or the NSQIP or both provide excellent predictability. Thank you all so much for your time and attention today. I truly appreciate your interest and engagement throughout the presentation. I hope you found the discussion insightful and that it sparked some useful ideas or perspectives. I'd be happy to take any questions you might have or hear your thoughts and feedback.